Thank you. Oh, that's okay. All right, guys, back to advanced directives. So your living will, what is your living will?
It says what you want your wishes is.
Yeah, it says what you want your wishes to be. So it might be one page, it might be, there's no voice at all. Actually, I was trying to even play a video and I couldn't get the speaker to work. Okay, so your living will kind of gives an idea of what you want. So let's say, does anybody have a living will? None of you guys in here has a living will? Y'all, how old was Terry Schiavo? I don't think so. I think she was in her 20s. I don't know exactly, but I know she was really young. Like, she would have been like, what do you mean? I don't need anything like that, right? Maybe. But it's important at least to let somebody who's, you know, would be your next of kin to know what you want. Because otherwise, something could happen today on the way home and everyone's standing around going, I don't know, what did she want? I don't know. And you can make it whatever. Like, you can say, I'm a DNR. I don't want anything done. Just when I die, I die. Are we going to, in their 20s, 30s, 40s, probably even 50s and 60s, make someone a DNR, though? Probably not unless they have a lot of health issues, right? Someone who goes in, so I'm going to use my grandfather as an example. He was super healthy until they moved here in July. In August, he started getting like CHF type stuff going on, but it's because he had a bad mitral regurg. So that caused the it caused AFib, which caused the CHF, blah, 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 just, you know, goes downhill from there. We get to the hospital and they say, does he have a DNR? And I said, no, but we want one. I don't have it with me. Yes, he needs a DNR. The doctor looks at my grandfather and says, you're not breathing very well, so you know, if I need to put you on a breathing machine to help you breathe, I can't do that if I put you on this DNR that she wants. And my grandfather goes, oh, I have one of those machines at home. Of course I want that. He's talking about his oxygen concentrator. What's the doctor talking about? A ventilator. And so he's letting my grandfather believe that it's the oxygen concentrator. And I'm like, no, he's talking about putting you on a ventilator. And, you know, he is at this point, he can't breathe, so he's like, do whatever, you know, the doctor says. So I get up to the floor, and the he's in the CCU. At this point, they didn't sign a DNR. The nurse comes out and says, I hear there was some screw up with his living will or something. And I'm like, well, yeah, we don't have a copy of it. I said, the doctor refused to make him a DNR. He needs to be a DNR. He's 92 years old. He's sick. His heart, I mean, this is it. We know that this is it. So we don't want him prolonged for 6 weeks in an ICU just to take him off and let him die. And he goes, well, maybe this is the time right now then for you to go ahead and just make him CMO. I said, I'm not going to make him CMO. I want the water, you know, the fluid taken out of his lungs. He needs a thoracentesis. He had one a month ago. He needs another one. If I say, go ahead and make him a CMO, you're going to give him a whole bunch of meds, and, you know, that's that. So he was all sorts of mad at me. I'm like, this guy has no idea who he's talking to. But I was thinking, if my grandmother was there by herself and this nurse came out and said this, she'd have been like, oh, yes, whatever you think is what I need to do, you know, because that's what she does. And so it's really hard to see from a nursing standpoint or a medical field standpoint some of the things that happen, and you wonder, oh, my God, how many times does this happen to patients on a daily basis where maybe something could have been done or things were done that shouldn't have been done, and it's really scary. So make sure that somebody knows what you want, that can stand there and stand up for you and say, no, she would never have wanted that, right?
Because they don't want to be liable just in case that's not his wish, and with her not having the paperwork, it's kind of like what she said.
So here's the thing, though. So when we get a little bit further, so my grandmother would be his next of kin, right? So no matter what, even if he had a signed DNR, if she said, "Oh no, do CPR," then they'd have to do CPR. So it gets really fuzzy. But the fact that I'm standing there with my grandmother and we're saying we want him to be on the DNR and the doctor was saying no, ethically that's not okay. That was absolutely not okay for that doctor to do. But like I said, a lot of people just don't know better, so they're going to go with whatever that doctor says, especially if they're of the older generation, because the doctor's always right. Whatever the doctor says is gospel. So as far as like why would they do that though? So I work for hospice. What do you think the average stay in hospice is? Hi. Pardon? Yes. Hold on, let me pause my recording. It'll come back up in a second. So yeah, so just know that it can happen, and it's horrible that there's even a chance that it might happen, but it does. And that's why, I'm sure going in the homes where the family's there, it does happen a lot more.
I have all this stuff I just got on. I'm new to this place.
Yeah. I was telling her a story. One of my old students, she worked for a nursing home in the area, and she was like the supervisor on the 3rd floor, but she was in the dining room on the 2nd floor, and there was a patient from the 1st floor in the dining room. So like, not only did she not know the floor, but then that patient wasn't from that floor, so none of the nurses knew him. And the computers were down, and he coded. And so she started asking everyone, is he a DNR? Is he a DNR? Is he a DNR? Nobody could answer. Oh, let me get in the computer. And people are trying to get in the computer's locked up, they can't get in. So she's like, well, and she just started doing compressions. The facility called DCF on her for doing compressions on him when he was a DNR. I said, do you guys have bracelets and stuff on them? She's like, they're supposed to. He didn't have one on. So obviously she was fine, but they called DCF on her for doing compressions on someone that was a DNR. But like she said, I mean, you're kind of covered, your butt's covered that do no harm. She wasn't doing it knowing that she was causing any sort of harm. Organ donation, it's a decision usually that you make as yourself when you go in to get your license. I know some of you guys probably have it on there. It says organ donor right on your license, right? Or if you don't have it, they'll ask your family, especially if it's a young, healthy person, they'll ask them about organ donation. And there has to be permission from somebody, though. And it's a bit of a process. There's certain people. Who's dealt with death in the hospital? So there's certain places you have to call when someone passes away. It's not as easy as like, oh, 204 died, someone call the morgue, or someone call the, whatever the funeral services people are here. They have to call the organ donation place, even if they're not an organ donor, just to let them know, because then maybe they have it in a bank somewhere, I guess. But there's several different places you have to call. There's lots of paperwork to fill out. You always, there's family. The doctor has to come and pronounce, and so it's not an easy peasy type thing. But the organ donation definitely becomes part of it.
Isn't there some rules as to if a person is an organ donor, what to do after you call them?
What do you mean?
Do they come right away, or to preserve the organ, or?
Oh, so yeah.
When it comes to the organ donation, I thought if you knew that they are going to donate the organ, then you keep working the code because you're trying to preserve everything.
I don't know. I've never encountered that.
Right.
Do you know any, like the...
If you know that they're already an organ donor, yeah.
They would usually just vent them and then keep them oxygenated. Even if they were dead.
Them on the phone, they'll give you specific instructions. Like, they'll tell you when the eyes, if the eyes shut, if you want to preserve the corneas, and depending on their...
That's not when you got time and you got plans.
Right. At all, even if they do volunteer to be an organ donor. But most people will...
Bless you.
They'll usually skin from anybody, and you don't necessarily have to vet them for that, but their eyes and any major organs. So usually with your younger patients, there's a lot more involved.
So palliative care, end of life care, hospice, what's the difference? It's palliative care is kind of like the umbrella for all of it, right? So here, though, in Suncoast, and I speak to Suncoast because I know that there's a new one, but I don't know anything about them and if they even have like other services other than hospice. But under Empath, we have the Suncoast Hospice, which is who I work for. But then there's a whole other department over here called the palliative care team. 2 doctors, a couple nurse practitioners, and some RNs. And if they don't qualify for hospice because either they have longer than 6 months to live, because we have to, and we'll get to that in the next couple slides, or they aren't necessarily done trying to fight the cancer that they have that's killing them surely but slowly, or even like my grandfather could have definitely used palliative care with all the CHF. They just have to have this is their quotes, a life-limiting illness. So it's got to be some sort of terminal illness that eventually is going to kill them. But it doesn't say within 6 months, which is what hospice is. And with palliative care, you can still be using curative. It's not only, comfort. End-of-life care, just like it sounds like when we talk about end-of-life care, it's usually that last couple weeks, week, hours. So the goal of palliative care is basically to relieve the signs, symptoms, pain that's happening from this life-limiting illness. And I feel like the next couple where it says regard dying as a normal process and to affirm life and neither hasten nor postpone death is more like a hospice, because I feel like at that point we're starting to talk about death more, so it's more going into those last 6 months maybe. But they definitely do talk about it in the palliative also. Definitely holistic care. What does that mean? Right. So you're not just cancer in bed A, right? You're you in bed A. So we want to treat everything. And I'm not talking about like treating your colds, treating your breathing, whatever. It's treating your spiritual needs. It's treating your comfort needs. It's treating, we have music therapists. We have hospice is mostly volunteers, without, minus the medical staff. But as far as like people that go in, I had a student a couple semesters ago who was a hospice volunteer, and like 3 days a week she just went over and hung out with people at their houses and like played games, played cards, helped them clean up. They rely heavily on volunteers. They offer support to patients to live as actively as possible until they actually pass away. So let's say that you really love the symphony and you're like, oh, but I'm dying. I'm just gonna sit here and, I'm too old. I can't do any of that anymore. I'm just wasting away my days now until the angel of death comes. Because they say some of this. Sometimes they say this stuff, and so part of the job isn't just being there to be their nurse or be their nurse practitioner or be whatever. Part of it is helping them to go ahead and do those things they like to do until they possibly can't anymore. Offer support to the family during the patient's illness and their own bereavement. So the one story when I first started at hospice, the foundation, so you guys know what the foundation here is, they're the ones that give all the scholarships and everything. Hospice basically has their own foundation. It's like the Friends of, everybody has Friends of groups, nonprofits. So they basically take money that then they use to help the patients and do things that normally they wouldn't be able to do. So they told this story about this lady. She was 38 weeks pregnant. She had been trying to get pregnant forever. She kept miscarrying. She did IVF. It wasn't taking. She finally, miraculously got pregnant. 38 weeks. She had a beautiful, normal pregnancy. She goes into the doctors, and the doctor says, oh, we're going to deliver the baby now. Looks like he has a little hydrocephaly going on, so his head's measuring really big. Ends up, baby's born with an inoperable tumor. Mom's like, all I want to do is take my baby home. That's it. Baby's dying. We know baby's dying. Baby's on a ventilator. Hospice goes in, and she's telling hospice, I really just want to take my baby home and have my baby at home for the last days and, just have our time. So the hospice foundation goes in and says, I don't know how we're going to do it, but we're going to do it. And the lady's like, what? And everyone else is like, don't promise things we can't do. And she's like, I don't care what we have to do. We're going to do it. And they spent a bazillion dollars, basically moving this baby and this vent. And she's like, we had no idea what we were doing, and we had them like on a generator. And we'd move the generator, move the vent, move the baby out to a van. And then they did the same thing into the house. And they wanted to extubate baby at home so that baby could die at home with mom, because that's what mom wanted. So they extubated baby. Baby ended up living 42 days. Mom got 42 days of having that baby at home, breastfeeding, having a normal mom-baby thing until baby finally passed away. So that's just one of those things where, you know, they support the family's wishes. I know, goosebumps, right? I love that story. And so it's one of those things where if that hospice was never called, mom would never have been able to take that baby home and have that time, right? Maybe they would have extubated baby eventually at the hospital, like the same way, like thinking that the baby was just going to pass away, but then they would have just been stuck in the NICU with all these tubes and everything else until baby passed. So this way mom got her wish, and it benefited mom and baby. And so a lot of the stuff we do in hospice benefits the family as well as the patient. So we try and explain that to the patients. Sometimes we'll have, or to family. Sometimes we'll have, I had this older woman who only had a couple days left, maybe, in the hospital, and this is going into why do they do these things? Doctor says, I don't think patient needs hospice. Outside doctor on the phone with daughter, just take her off her oxygen. She's gonna die. This is what the doctor is telling the daughter at the hospital. Meanwhile, myself and the resident at the hospital are like, let us consult hospice. We want to get hospice in, whatever. So either doctor doesn't see the benefits, or we have the opposite where doctor thinks, no, there's no way I can do more. I can save this patient, because that's what they're trained to do, right? They're not trained to do the palliative care and help patients die, and they probably are better trained now than they used to be, but still, in the hospitals now, you'll still see it. Patients that you're like, this patient should be on hospice. Happened with my grandfather. His primary care did not want hospice because he thought, I'll just get the fluid off and he'll be fine. Okay. It's just a big frustrating circle that goes around and around. And what ends up happening is finally you get the family to agree to hospice, and then the patient dies, right? So they don't even have a couple days maybe on hospice. The average patient stay in hospice is less than 2 weeks, which is ridiculous because, I don't know. It's my soapbox, sorry. Okay, so what is hospice?
Hospice is not what they're foregoing, like they're still going to cure you.
Not a death.
Concept, not a place. You have a copy of my thing over there?
No, I actually
What does it focus on? Quality and comfort at the end of life. Yeah, the first one says concept, not a place. So hospice isn't a place, right? You don't go to hospice. We do have a hospice house. They actually have 3 here in St. Pete, the Suncoast does. Every county in Florida has their own hospice. Some hospices are over several counties. There are a couple hospices that are federal, but in here, so we just do Pinellas County. So we have at Bayfront Hospital, which is the one you guys will be going to. Countryside people, you guys are going to be going up to the Tampa Road one. Are you guys going to the Tampa Road one too? So you guys are going up to the Tampa Road one too. Or maybe you guys are going to Brookside then. No, Brookside is the Tampa Road one. And so they do, but we don't, it's not like the one in the video where the woman lives there. Ours are symptom management, because the whole thing with hospice is what? To keep you where? At home. We want to keep you at home, right? Doing your things, living your life until you can't. Yeah. I can't hear you.
What if they're homeless?
Well, if they're homeless, then we see them for as long as we can, wherever it is that they're at. And if anything needs happening or needs to be done, or they start actively dying, then we admit them to the hospice house, one of those 3 places, and they stay there usually until they pass. Usually the average stay at the hospice house is only 2 days, because it's just for symptom management. So say it's your patient with CHF and they're super short of breath, and you no matter how, or you're trying at home with medications, you can't get it under control. So then they go to the hospice house, and then we get it under control and we send them back home. So one of the things that we are very adamant about with the family is when something's going on, you don't call 911, you call us, because then we send out the EMS to come and take you to the hospice house. If they get taken to the hospital, then basically hospice is put on hold until they're discharged from the hospital. So lots of things happen at the hospital that maybe the patient didn't necessarily want. Otherwise, they probably wouldn't have been on hospice. So usually it's limited to the last what?
6 months.
6 months of life. Good. Assists patients to fully live as actively as possible. Oh, I don't know. I probably just didn't put 3 things. Includes symptom management, family care, spiritual care, and bereavement. Care is provided in the home. Oh, and one of my words is completely missing from the other one, bottom one, but it's a multidisciplinary is what that bottom one is. Hospice is multidisciplinary. So the goal is to reduce the severity of the disease rather than providing a cure. So does that mean that if a patient has a huge tumor on their aorta that we're not going to do chemotherapy?
It helps to reduce.
Right.
Yeah.
So we're not going to do it to cure, but sometimes they'll use radiation, sorry. Sometimes they'll use radiation to shrink a tumor if it's causing discomfort. So they still can do palliative things that you would normally think of as like a curative, like chemo and radiation, as long as it's not being used as a cure. So we are decreasing the severity of the disease symptoms.
Now, if you radiated chemotherapy and it's now small enough to do surgery, is that?
If the patient decides at that point to do aggressive treatment, then we would discharge them from hospice. Sometimes, though, at that point, palliative care will pick them up. So they're still going to get the care. They're still going to get nurses coming in. Medication will be done through palliative care. Because there's a lot of things like hospice isn't just us going in the home like a home health care, right? We provide all their medicines, all their DME. They call 24 hours a day. We have comfort kits locked up in the house. If they suddenly start actively dying and nobody can get to them, they have morphine and stuff there. Like, it's more than just us going in once a day and visiting. And a lot of times they are seen at least once a week by an RN. And then there's home health aides that can go in up to 6 days a week. And then we have the spiritual care coordinators. We have music therapy. There's a whole bunch of us. So the unique characteristics of end-of-life and hospice care is that quality of life. We want to make sure that the patient and their family feel like the patient has some sort of quality of life. Freedom from pain. Symptom management, preparation for death, achieving a sense of completion. What does that mean? No regrets. Coming to terms with life, coming to terms with being comfortable with the fact that you've done everything you're going to do and you know, being treated as a whole person. So we're not just there poking and prodding at their leg because they have gangrene and that's what they're dying from. We're actually treating them as a whole person, right? So criteria. For hospice, the patient has to desire services. Or they're a caregiver if the patient is deemed incompetent or if they're unconscious or Alzheimer's. But someone has to desire services. They have to want the services. A doctor has to certify, actually 2 doctors have to certify that the patient has 6 months or less to live. And believe me, we have all these algorithms. Oh, you're dying of end-stage renal disease. Hold on, let me flip to my book. End-stage renal disease, they have to meet these criteria. And what usually happens is it's usually like the outside doctor will call and refer, and then one of the hospice doctors will be the second certifying doctor. Does that mean that you can't call and say, I really think my grandpa needs hospice?
No.
You can. So what we'll do then is we'll find out who their doctor is. We'll call them. We'll talk to them. We'll have them say, sure, yes, absolutely. And then the hospice doctor will be, again, the second certifying. We talked about this. I said we give them all their medical supplies, their medications. So we have this list of, this is what their primary diagnosis is, and these are their related diagnoses, and then these are their unrelated diagnoses. So we will supply medication for diagnosis and related diagnosis. Anything else the primary physician still takes care of. Does that mean that if I am on hospice for COPD and I get, I don't know, really sick with something else that we can't treat that, we can't cure his pneumonia or his anything else, UTI? No, we're still going to cure that stuff, right? We're never going to let anybody sit there and die of sepsis. So when we talk about it can't be curative, it's just that diagnosis and the related diagnoses. So if they get a UTI or if they get, a CHF exacerbation, we're still, I mean, you can't cure CHF, but pneumonia, an infection in their leg, we're still going to cure that stuff. The hospice physician will write the orders. We talked about the short-term inpatient care. It can be up to a couple weeks, but normally it's only a couple days. Sometimes the families, when it gets towards the end, they're just not comfortable with their family dying in their home. So they'll call and we'll transfer them into the hospice house and let them pass there. Grief and loss counseling for the patient and family for 2 years. So the family has 2 years of grief and loss counseling at no cost through Suncoast. We talked about all the different interdisciplinary people who are part of our team. So what do you think these mean as far as barriers to hospice care? Why would communication and language barriers be a barrier?
Because maybe you guys don't have enough bilingual staff.
Oh, they have lots of bilingual staff, and we have the blue phones and everything else. No, so this would be like in the hospital, maybe they're not understanding what you're saying, and to them, the word hospice means something completely different in their country, right? And so you're trying to explain it, and they're like, and you're like, okay, so we're going to do this, and they're like, no. And you think that they're understanding, but they're not. So there's some sort of language or understanding barrier. Underutilized by minorities. And maybe it's just because I live on the south side, so I work on the south side, and there's a large African American population there, so I see a lot of minority patients and a lot of Asian patients. So I don't think it's underutilized, but I guess depending on what part of the country you're in maybe, and I don't know why it would be underutilized except for the fact that there are certain cultures that believe in caring for their elderly, and they feel like that is their due thing that they have to do, and no, I'm not going to let you do it because this is what we're supposed to do, right? So I think maybe it's more of a cultural thing than a minority thing. Lack of knowledge, again, people just don't know. You say hospice, they say, oh, I'm dying tomorrow. Or you say hospice, and she says, no, then he's going to think I'm giving up on him. I'm sure, has anybody had family members in hospice or had this discussion where it's like back and forth? And my stepdaughter called me once, and I guess she'll be 28 next month or the month after. So she calls me and she says, my grandpa's passing away. I can't get my grandma to agree to hospice because she feels like she's just giving up on him. She's like, but he literally has days, maybe a week. But they think that if they sign the hospice paperwork that he's going to die and that's it. That's the end. So that's how people think. They think that they don't want grandpa laying in the bed to think that I'm giving up on him by signing those papers, right? I had the same issue with my grandmother. So when we talk about the physical and psychosocial manifestations of approaching death. There's a couple slides, or a couple boxes in your book. So here's one of them, and this is actually out of an older book. So the book that you have, it's not 11.2, but it's in it's closer to the front of the book somewhere. I'd have to. I don't have 9.2, so it's chapter 9.2, table 9.2. But it's the exact same table. So what's the last thing to go? Hearing. So do you think that if Joe is laying here in the ICU and he's intubated and his heart rate's like nothing, blood pressure is nothing, and his kids are there fighting over who's getting the house. No, I'm not paying for a funeral. That man was a bastard. We're going to burn him. And, you know, do you think that patient can't hear them? They absolutely can hear them. Yes, it does happen. And so just be really conscious of the fact that hearing is the very last thing to go. And make sure that you tell the patients that. Pull them out of the room if you have to and just say, I just want to let you know. And then if they still do it, then you say, maybe you guys can leave, leave for a little while, have your discussion, and then come back. Because really, I mean, even the patient who's that close to death, you're still an advocate for that patient, right? I had a patient once who passed away, and his daughter had been there. So his daughter went and got the mom, and he hadn't passed away yet, really sweet guy. And so they sat bedside forever, and I just kind of was out at the nursing station. It was super close to the nursing station, and his daughter comes out, and he goes, hey, can I borrow your stethoscope? I think my dad just passed away. I don't know, maybe she was a nurse. What do you say? I'm like, uh-huh. So, but at the same time, I hear the wife screaming, no, Jen, no, because I guess that, you know, if I gave her the stethoscope and they listened and there's no heartbeat, then it says he's dead. So we go in, we pronounce, blah, 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 we leave the patient in there with the family for however long. They finally leave. I go in to do the post-mortem care, and he has like a tear in his eye. And I was like, poor thing, probably, you know, he probably heard how upset, as he was just passing, probably heard her screaming. I know. Very sad. So hearing's definitely the last thing. So tell me, what are some of the manifestations that you guys have seen, if you've seen any, in your job, if you work in a nursing home or the hospital, or well, you've been in clinicals, of someone who is in their last hours of death?
Their breathing changes.
Yeah, their hands and feet turn blue, their breathing changes.
Earlobes lay flat.
The earlobes lay flat. I never, really? I have never seen that or noticed it. Yeah, I'm gonna have to now though. The stare. Yeah, a lot of times they're just staring.
Or either their eyes, they change color.
The eyes change color. They get cloudy or blue sometimes. They're cool and clammy. Yeah, they don't have much sensation. What does their skin look like?
White.
Yeah, so it's mottled and it's white, right? Because it's waxy looking, isn't it? Yeah. And they get a lot of secretions. Mm-hmm. And now the thought is we used to just suction the heck out of them. Or put scopolamine patches on them, or give them epi, or, you know, something. And it just causes the body to try and produce more, so then it's a never-ending battle. So now we just kind of roll them on their sides. Doesn't bother the patient. Bothers the family a lot more than it bothers the patient. But we just kind of lay them on their sides so that it naturally can drain, because it's just from them not swallowing, and usually it's just stuff right up here. And the patient's not bothered by it at all.
So if somebody is passing and they're running temperature, what do you guys do?
If they're running a temperature?
Mm-hmm.
What do you mean?
Like if they're running temperature.
Like they're actively passing, like
Mm-hmm.
Cheney Stokes,
Everything.
secretions everywhere,
Yes.
nothing. I wouldn't do anything.
Ah, okay.
I
I had a
mean,
patient, and it was hospice patient, and he was dying, and he was running temperature, and I called hospice, and they're like, okay. I'm like, what?
yeah.
They have the suppositories.
They do. You can do the suppositories. We actually have a Macy catheter too, which looks like a Foley catheter, but it's smaller and it goes into the rectum, and the patients apparently don't even feel it. But we liquefy medication and put it in, and so pretty much anything you can take orally, we can give rectally. So they'll put a Macy catheter in, like if a patient's at home and the family's not real comfortable, or if they have to get phenobarb at the end of life.
Sometimes swallowing, they can't swallow.
Yeah, you could. I mean, you definitely could do something. I mean, it depends. I don't want to say that if someone's like in their last days, obviously we'd give them something. But if it's someone who we felt like was, you know, a lot of times the respirations will be all wonky, but then the blood pressure all of a sudden starts going up. So people think, oh, he's doing really well. His blood pressure's up. No, that's the body just trying to compensate. So maybe the fever would be the same thing. I don't know. Psychosocial manifestations. What's a life review?
When you start going back to the past.
Yeah, when you just want to talk, they start telling you stories, right? So, I'll tell you, if I'm at the hospital and I have 6 patients, and I have someone who's actively passing away, like we know he's not going to last the next 24 hours, and he wants to start telling me old war stories, and there's no one there to sit with him, either I'm going to find someone to sit with him, or I'm going to sit with him and have the other nurses split my patients, right? Because this man is dying. These are his very last moments. For some reason, he feels he needs to tell these stories over and over again. Why? Because that might have been the happiest moment of his life. So he wants to tell the story so he can relive it. I'm not going to deny somebody that in their last minute's life, you know? Peacefulness, obviously, we want them to have the peacefulness. Do they always have peacefulness when they're dying? No. We'll try and create it as best as we can. Sometimes they get super restless. They get real anxious. Sometimes they want to say goodbye. You guys have all heard the story. Uncle Joe should have died 3 weeks ago, but he's been holding on, and then Bubba came and he saw Bubba, and then he passed away an hour later. Like he was waiting to say bye to Bubba, you know? Unusual communication, so maybe they're talking to their parents who died 40 years ago. I hear that a lot when I go in and I'm doing the recertifications, and I'll say, have they been hallucinating or anything? They're like, oh yeah, he's always talking to his dead brothers and sisters. Vision-like experiences, so again, maybe they're actually seeing them there. Sometimes they withdraw. They don't want to talk. They don't want people there. Again, sometimes it's a cultural thing where, no, I want everyone to leave. And sometimes they don't die until they leave. So my grandmother sat at my grandfather's bed from like sun up to sundown every night. And then the very last day, I finally convinced her to put him on hospice, and they were going to send him home with hospice. She had a doctor's appointment, so I had her with me for most of the day. I dropped her off at home. She texted me and said, he's actively passing. We need to get back to the hospital. And I really think he just waited till the day that she wasn't there and let himself like finally go. Because sometimes I feel like they hold on for the family. You know, I don't know. I mean, who knows? Altered decision making. That's why we have our healthcare proxies, right? Our healthcare surrogates. Fear of loneliness. Sometimes they have this huge fear, and so you'll be running into a room, and they're like, "Oh, just stay, just stay, just stay." What do?
You stay.
You stay, or you find a volunteer, or you find somebody not doing something. There's always the pink ladies up at the front, or you can call the chaplains, clergy. Is that what they're called in the hospital? If you're at the hospital and there's a patient that doesn't want to be left alone. Fear of meaninglessness. So maybe they'll start going on about how they feel like they didn't achieve everything they wanted to achieve in their life. And again, these are situations where all you can do is sit there and listen. Fear of pain, that we talk to them a lot about. We assure them you will not have any pain. So what happens if your patient is actively dying? They have respirations of 9, blood pressure's 86/42, and they're complaining of pain. Give him the pain meds. Are you going to kill him? No. So you always hear, I don't want to be the one that kills this patient. I'm going to push that, and he's going to die like 3 minutes later. You know why he's going to die? Because he's finally relaxed enough that he's going to die. You giving him that medication did not make him die. Helplessness. I don't want to feel like at the end of life, especially I think this happens more with the younger or the very stoic men, where they don't feel like they want to let you do anything for them. And they feel helpless because they can't get up and do it themselves, and usually it turns into some sort of anger.
Question.
Yes.
So the pain of dying is rushing epinephrine through you, and that's what's keeping you alive? You're losing morphine, the pain go away, makes you relax?
No, but
Is that
no. No, I'm just saying people have this misconception that you're giving them the morphine and their respirations are already low and you're going to kill this patient. No, it doesn't happen. I mean, if it does, it's probably just the patient was really upset and, and now they've actually relaxed, kind of like your patient who was waiting for everybody to leave. They finally can relax and lay there and,
I have a question.
Yeah.
So, a patient's respirations are 9.
Mm-hmm.
Isn't morphine a respiratory
Mm-hmm.
device? So,
Your patient's dying.
right, they're already dying.
Mm-hmm.
But aren't you?
We're not going to hold their pain medicine.
I'm not saying hold it, but I'm saying
So this was the point of this conversation, though, because normally if you're in the ICU and you have someone who's a healthy person that just went through surgery and they have a respiration of 9, well, they're really close to being intubated anyway, but you're not going to give them a bunch of morphine.
right.
It's a whole different world in hospice.
I understand it's a whole different world, but you're saying you're not killing that patient or you're not assisting.
You're not
You know what I'm
killing
saying?
them.
I'm trying to make them not feel the way you're thinking. Like, patient has a respiration of 9. It doesn't matter with these patients.
I've worked hospice and I've sat with my relatives through hospice and I've medicated my relatives until they were gone.
Yeah.
So from experiencing it and from watching a loved one get a dose, the first dose of morphine and Ativan back to back and then stop breathing immediately.
Yeah. So I walk out of the room type of deal.
I mean, that's kind of a different, and you're saying, but that's not what you're doing.
Right.
Isn't it like trying to like dress it up and make it like that's not what we doing?
Florida doesn't have a physician-assisted,
She have to go to Switzerland.
yeah,
Well, the
or
physician-
Oregon or Vermont or Washington.
I'm not,
It's just complicated.
To that effect.
We-
Treating the pain.
We're not doing it to kill the patient. We're treating the
right, I
pain.
understand that's not,
But my whole-
you're not doing
Right.
it so that they die.
Right, but the
But
whole,
you're doing it and they die.
and sometimes that happens.
It's gonna go down either way. though.
But
Right,
you doing
right,
that
I agree with that.
isn't hastening it. It was happening anyway.
You can let them suffocate, or you can let them go off on that.
Because a lot of times when
But
we
if you
use,
didn't give that dose, were they gonna die in 5 seconds?
maybe. So a lot of times we use morphine for shortness of breath, and it doesn't stop the shortness of breath, but it affects the brain in a way that the patient doesn't feel that anxiety over the shortness of breath. So, I don't know. I get what you're saying.
And I get what
I
you're
know.
saying. It's just like
I know.
a line that.
It is, but again, these aren't your normal healthy patients.
Right, and I
so we
understand
never
that
withhold. Same thing. So if you're a patient, let's say your patient's dying and they're having a hard time breathing, are you not going to give them the morphine or a breathing treatment or a bronchodilator if you can, if they can take it and you can give it to them? Yes, you're going to do that, right? Because we're not going to withhold any treatment. So, the importance of culture, ethnicity when planning, providing, evaluating care. So, tell me some that you guys have run into, or that you, maybe your family or your background, differences maybe in the way that you perceive or care for a loved one dying, or a ritual that's maybe done.
Open the window after
Jewish, what?
The Jewish religion has something.
I don't know, and I'm not a pro at this, but I believe that they have to be buried within 24 hours.
That's the
Muslim.
Muslims have to be buried.
I know,
like,
see?
in the land.
I don't know it all either. And then she said something about opening a window to let them escape after they die. So
Turn the mattress over.
turn the mattress over. I've never heard that one.
Yeah.
So, but the point is, kind of know your population, talk to the family, talk to the patient while they can still talk to you, and get to know what their belief is and what's important for them to happen when they pass. Is there anything that we need to know, any religious or spiritual, anything we need to know to ease this for you, or, talk to the family? Is there anything he would want us to do, or So just knowing, kind of being comfortable enough talking to people to find out what their cultural or ethnic background says regarding dying. And so tomorrow when I go into Ovid, I'll show you guys that whole section with the culture where you can literally look up like any culture and it'll tell you how to talk to them about end of life, how to talk to them about pain, how to talk to them about, it's really cool. So the stages of grief, you guys all remember these? Did you learn them in psych, I'm sure? And I'm sure that you guys had to take some sort of like, what was the name of that course? I remember a course like all my pre-courses, something really hit on the...
General psych?
No, I don't think it was general psych. It was like the life cycle something. I don't know. So they all start in denial, right? No, I can't have cancer. I'm like 42. I have a 7-year-old. I'm healthy. I can't. No, absolutely not. And then all of a sudden it turns into anger. This is ridiculous. There's too many things I need to do. I have too many things going on. And then there's the bargaining. Well, maybe if I do this, it'll go away. Or maybe if oh God, I'll do this. I swear to you, I'll never again run a stop sign, whatever. Just don't let this be true. And then they finally get a little bit of acceptance that turns into depression. And then once they work through that, it could turn into acceptance. How long is this process going to take? Maybe. It could take forever. It's all going to depend on the person, right? I can't say this takes 32 days. So it's all going to be dependent on the person and the situation. So how can you assist the client and family in coping with suffering, grief, loss, dying, and bereavement? So we kind of talked about it all, right? So make sure if the family is there that you talk to the family, find out what you can do. I mean, literally just ask, what can we do to help you or the patient? What would he have wanted? What do you want? Honestly, it's just keeping that communication open makes a huge difference. With hospice, like I said, they get 2 years of bereavement. Maybe it's a year now. It used to be 2 years, I think. But still, they get counseling. They get the spiritual care coordinator, which isn't, any specific denomination or a religious thing. It's literally just, she'll sit there and talk to you and let you talk about whatever you need to talk about. Did we talk about spiritual distress? So maybe someone who has never in their life been a religious person suddenly feels like, what did I do to deserve this? I must have done something. God's punishing me, right? So what can you do for that person? Lots of listening. Offer the chaplain or the clergy or the spiritual care coordinator, whoever's there. Just try and let them talk it out as best as they can. So we're going to go to dinner in like 3 minutes. Husband and daughter of a Hispanic woman are dying from pancreatic cancer, refuse to consider using hospice. What should you do?
Clarify the understanding of what hospice is.
You guys think that's the best one? And it might be 4, but the best answer here, because this is nursing school, is to make sure they understand what you're even talking about. And it might be that they want to care for their own and they don't want help, but first you need to make sure they understand what you're offering. So it's 1. One, yeah. Terminally ill patient is unresponsive and has the Cheney-Stokes respirations. Patient's husband and 2 kids are arguing at the bedside. Oh, we talked about this. Where the patient's funeral should be held. So what should the nurse do?
2.
2? Yeah. Take the family members aside, explain that they can, she can still hear you. Terminally ill man tells the nurse, I've never believed there's a God or afterlife. Now it's too terrible to imagine that I won't exist. So why was I here in the first place? So what is this patient experiencing?
1.
I know, we just talked about it. Spiritual distress. Yes. Patient in the last stages of life is experiencing shortness of breath and air hunger. So based on practice guidelines, the most appropriate action by the nurse is to what?
Four.
Yes, 4. Any measure to make that patient more comfortable. I think this is the last one. End-of-life palliative care, nursing care involves what?
Four.
Yes, 4. In assisting with the patients with the dying, end-of-life care promotes the grieving process, which involves saying goodbye. Physical care is very important for physical comfort, but assessments should be limited to essential data related to the patient's symptoms. Oh, primary purpose of hospice is to
Coordinate care. Provide comfort and support for the dying patient.
the primary purpose is number 4, to provide comfort and support for the dying patients and their families. Yes, we allow patients to die at home. All right. So that's it.